Welcome to the Crisis Response Podcast, a show about the regular folks who are tackling major problems and transforming how communities watch out for each other. I'm Jason Friesen, and on the show today, how Molly Klarman and the MotoMeds team launched Haiti's first nighttime pediatric health crisis hotline, managed it through civil unrest, hurricanes, and fuel shortages, and then scaled it in the immediate aftermath of a devastating earthquake. Hello, Molly, and welcome to our podcast. How's everything going?
Hi, it's going well. Thank you.
So, Molly, you are the director of MotoMeds in Haiti. Could you share with us what is MotoMeds? What does it do? How does it work? What are you focused on?
Okay, so MotoMeds is a pediatric nighttime telemedicine and medication delivery service. It's currently operating in 2 cities in Haiti. And the idea is to bridge the gap in access to pre-emergency treatment for children at nighttime. So when we talk about pre-emergency treatment, this would be for common childhood illnesses like acute respiratory infection or diarrhea, other infections like ear infections or urinary tract infections. So these all have well-established cost-effective treatments, but they need to be administered early. And so in countries with low resources and that don't have great healthcare systems, there's a gap in access to these types of treatment once the clinics are closed. So most local clinics close in the afternoon around 2:00 or 4:00. And if you need care at this time, your only options are emergency care or waiting until the morning. And young children are vulnerable to illness progression. So for some of these children, if they wait until the next morning, they now have an emergent illness, which is you always want to prevent emergencies from happening in the first place. But when you're in one of these resource limited settings that may not have emergency care, or it could be prohibitively expensive, it's more urgent to eliminate or to prevent these emergencies from happening in the first place. So that's the idea for MotoMeds. But how it works is we have a call center that's open at nighttime. So in Haiti, it opens at 6 p.m. and closes at 5 a.m. It's staffed by nurses or nurse practitioners, and they receive incoming calls from families with sick children. They use a set of guidelines and a standard operating procedure that our team has built to assess each child and then generate a treatment plan. And so most treatment plans involve a medication delivery. So we use TrekMedics Beacon to dispatch delivery drivers. They come to the office, pick up a backpack full of supplies, and then they navigate to the home of the sick child. They deliver the medications. We use a tablet to transfer instructions on how to administer the medication or how to take the treatment. And then some children who have, you could say, moderate illness, we will also send a provider. So we'll send a nurse to their house to perform an exam to make sure that the child can be treated at home. And if not, they will escalate care and refer them to the hospital. We can transfer patients to the hospital as well, but we don't take on that care.
So this sounds like a really useful service. I mean, anyone with children can relate that children tend to get sick at night. And like you're saying, common illnesses can progress and become a lot worse if they're not taken care of right away. That sounds all very novel and understandable. But one of the things that strikes me so much about MotoMeds is the area that you're working in, and specifically the topography. Can you talk a little bit about Gressier, Haiti, and the community that you're serving?
Sure. So Gressier is a small city along the highway that opens up into more rural mountainous areas. And we also work in Les Cayes, which is a more urban setting. But in Gressier, there's no streetlights. There's very few paved roads. There's no address system. So we rely on the local knowledge of the delivery drivers. And They have done an incredible job and almost always find the location that they're going to. With the only exception is sometimes we lose contact with the family because cell service is not great in these areas. Also, families have limited access to like electricity, so sometimes their phones will decharge. I'm talking in Creole. Their phones will lose battery charge, and so we don't get the full address from them. But other than that, the delivery drivers have been able to find houses like on side of mountains with no like I said, no address system. You usually use local landmarks, and then just like like I said, just their knowledge from their they all work as motorcycle taxi drivers. So like during the day, they drive kids to school, they drive like women to the market, they drive people to work. So they just know the neighborhoods.
These are motorcycle drivers.
Motorcycle drivers.
Yeah. Wow. So how did you recruit the drivers? How did you recruit the nurses, the nurse practitioners? Were you able to find them from the community, or did you have to go outside?
We started, before we launched MotiMeds, we did a needs assessment. So we interviewed families in the area to ask them about their healthcare options and their healthcare needs. And so we had a nurse researcher head up that project, a local Haitian nurse researcher who had worked for the University of Florida previously. And she had a preferred motorcycle taxi driver for getting to and from work, or send, she needed lunch or a soda, and she'd send him out to get those things for her. So we used him to recruit the other motorcycle drivers. And we had a couple meetings with them before we hired anybody. So we also wanted to get their feedback on the idea and whether they'd be willing to go out at night. There's not a lot happening in Haiti at night. Most people, because they don't have electricity, it gets dark and they go to sleep. So we weren't sure of people's comfort about going out at night or their willingness to go out at night. So we held meetings with groups of motorcycle drivers. We asked them about like their concerns and their interests. And from that group, almost everyone decided to continue. And so that's how we got our first pool of motorcycle drivers. And then when we expanded to our satellite delivery area in La Caille, we did a similar method. As we had a trusted contact who I think worked as a volunteer for the Red Cross, and he recruited a pool of motor drivers for us.
So you mentioned that they're hired. How are they compensated? Is it per delivery, or do you have them on a retainer? How does that work?
So the original idea was to have a pool of motorcycle drivers that work every night, and we would, you could say, broadcast a need, and whoever responded first, similar to like the Uber model, would get the job, and they would come to the office, pick up the items, and then go deliver them. But in those original meetings, the drivers wanted to share the work evenly. They didn't like the idea of like the first person to respond to get all the work. So what we decided to do, which actually ended up working out well when we were like at the beginning stages, because we wanted to like limit the number of things that could go wrong. So what we did was we decided to hold each night, pay a small retainer to two of the drivers to make sure that they would remain available, that they weren't, traveling far away, or they weren't at a party drinking. So they're basically, we call them on call. And then depending on like the needs of the night, we might use one, or we might use both, or we might use them multiple times. And then they just switch every day. It's two new drivers who are on the retainer. And then, so on top of that retainer, we pay them by the trip.
That sounds like it works out quite well then. I mean, they accept it and they're happy with that.
Yes. Yeah.
That's great. This is a question we hear a lot of, is we have people who are willing, but how do we make sure that they stay willing? And it looks like you've really found a solution, and one that came from them as well, that they're actively participating in the decision making. That's really impressive. What about the nurses? How did that recruitment happen, and how did you bring them in?
So we just advertised the position around to like local NGOs and clinics, and then interviewed Sometimes it's hard to read resumes in Haiti. So sometimes the universities, you don't recognize the names. You're not sure if they're reputable, or, the schools that they went to. It's because things aren't regulated very well. It's hard to get a feel for. So we ended up hiring most of the nurses we ended up hiring had job experience, like solid job experience working for a known entity, whether it's an NGO or a clinic or a hospital. And I contacted people to act as references for them to make sure that everything was as it appeared on paper. And then we did like a pre-test just to get their baseline knowledge, and interview questions, because we were also combining research with providing care. And that is not as common for some of these employees. They weren't as familiar with research and consent and data collection. So also asking them about their willingness to work at night and willingness to drive around on motorcycles. That was part of the interview process.
And how did that go over? Because the nurses are predominantly women, and the motorcycle drivers are predominantly men. And obviously the risks for traveling at night are higher for women than they are for men. But there are also risks for the men as well. Can you talk about what kind of risks they were concerned about and how you dealt with those?
So the drivers were mostly concerned about being on the road by themselves, because there's the possibility of having a flat tire, or your motorcycle breaks down and you're stuck by yourself, because like I said before, there's not a lot happening at night. So there's not a lot of resources to turn to. They were also concerned about being robbed potentially at night. And interestingly, they were concerned about hitting animals on the motorcycle in the dark, which would obviously cause an accident. And so we ended up using a buddy system. So most deliveries are done by 2 motorcycles together. Depends on the time and the situation and the location. But that definitely was a good solution to basically making them feel more comfortable. The nurses were more concerned about getting wet in the rain. They didn't. Yeah, I would say that was probably their biggest concern. I think for them, they knew they would always be with the driver, whereas the drivers sometimes will be on their own, and that's more of a risk. And then the nurses, most of them are from the area where we're working, so a lot of them were already familiar with the drivers, which I think helped them feel more comfortable going out at night with them.
Yeah, it makes sense. You're taking care of their security concerns just by the model. So you've recruited drivers, you've recruited nurses, you have the technology set up so that you can take calls in, and then you can dispatch the drivers and or nurses. So you're all ready to go. Now it's time to promote this to the community and raise awareness. What did that entail?
So I think that was the biggest unknown before we got started, is how much do you have to promote it, or how little you want to promote it? Because when we first started, we we did a lot of role playing. We tried to practice, receiving calls from community members, but we weren't sure how it would actually play out. So we didn't want to be overwhelmed with calls at the beginning. And that really would have, I think, been a disaster. So we started with very limited publicity. We contacted a number of participants in the first study that we conducted that they referred to, the needs assessment. We contacted all of them and said we had told them we might be potentially opening the service. So we contacted them to confirm that we were, and when start date and the phone number. And then we also did a handful of announcements at local churches, but not that many. And then we told our staff that they could advertise to their networks, their neighbors and family members. And so we did get a call the first night on opening night, but that was the only call for the entire week. So we quickly realized that we needed to increase the advertising. So then we started advertising at more churches, at like soccer games, at schools. We handed out flyers, we put up signs, and that increased the population's awareness of the service, and then increased our call volume. But it took us about a month to kind of get steady calls. And so when we expanded to Okai, to our first satellite location, we knew right away that we could, I mean, especially at that point, we knew how to handle calls too. So we could, we wouldn't have crashed if we got 5 calls at once. Whereas on day one, we probably would have. So we went all out with the advertising, probably like 2 or 3 weeks before no, maybe not that long. 2 weeks before we started, we knew that we couldn't, we wouldn't, we knew that it wouldn't be a bad thing if the more people knew about it, the better.
Yeah, that's something that we always talk about with organizations that are getting started. Is it's much better to start small and grow than it is to start way too big and then have to scale back. Because when you start scaling back very quickly off the bat, people are going to notice, and they're going to lose faith in the service you provide. So
exactly,
it's a lot easier to scale up than it is to scale back. So of the areas that you mentioned advertising, one of them that I think I noticed wasn't mentioned was you weren't doing a lot of advertising in other health clinics, right? Or at the hospitals.
So actually we did, sorry, I missed that. We did advertise at a couple local clinics. And so one of the aspects of our model is that we don't want to be in competition with daytime providers. So sometimes people say why are you only open at nighttime? But in Haiti, there's, 40% of healthcare is provided by the government. And so the rest is either by NGOs or private healthcare providers. And so that's what they do for a living. And we didn't want to take away their business by offering, so MotiMeds isn't free, but it's definitely subsidized. So we didn't want people to delay seeking care for clinical reasons, but also we didn't want people to not frequent their regular providers that cost money to wait to use MotiMeds at night for free. So we don't compete with daytime providers. And I think for that reason, the daytime providers were happy to put up signs for us or to hand out flyers and to advertise with us.
That's a really interesting point, that you don't want people to delay care, but at the same time, you don't want them to take advantage of your service and ignore the daytime services that are available. So that's a really interesting balance that you're meeting there. So for anyone who's paid attention to the news over the past couple of years, Haiti has experienced its fair share of disruption in the day-to-day life, both politically, socially, and in terms of security. One of the things that's amazed me over the years about MotiMeds is that you've never stopped providing services. And I'm wondering if you could talk a little bit about that, both about the challenges that you've faced and how you've dealt with them. Because, we're reading in the newspapers that after that abduction of the, 20 or so, I don't remember how many, it's 17 missionaries, I think it was, there's an abduction of 17. And all of the NGOs, and understandably so, closed up shop and packed up and left Haiti for fear of safety, but MotiMeds continues to operate. How has that been possible?
So I guess I could have 2 responses to that. So one is when you talk about a lot of the NGOs packing up and leaving Haiti, we are almost entirely run by Haitians. So it's not a problem if there's no foreigners on the ground in Haiti to help run the program. I would say one thing that our team struggles with a little bit is troubleshooting technology problems. So, when the internet's not working well, or a router or a speaker or a phone. You know, sometimes that can be hard for them to fix on their own. And then it's also hard to troubleshoot from a distance. But in terms of like, you know, staffing and management of the staff and people following protocols and like just general like employee conduct, everything is like run by our local team, and they do a great job of that. And then in terms of like how we're able to operate amongst the like political and societal problems in Haiti, when we launched MotoMeds, that first like 2 months was during a period of protesting. So like there's lots of like roadblocks along the roads, like burning tires. Sometimes they're like manned by people with like guns, and they didn't want like the society to function normally because they wanted to like, you know, make a point to the government that they were unhappy with the way things were going. But what was interesting is that like that all stopped once it got dark, like at nighttime. Like the burning tires went out and the people went home, and so the roads were open at night. And so like we were at first a little hesitant because we weren't sure if like that was dangerous or not, but realized that like there's no one out. And so it was fine to continue operating and doing nurse visits and deliveries at nighttime. I do have to say in this past month has been a little bit difficult. And what's happening now is there's like a gang that's blocking the fuel terminal. They're blocking the delivery trucks from accessing fuel at the terminal to distribute throughout the country. And so the cell phone towers are all run on diesel, and so they're running out of diesel, and so some of the cell phone towers are going out, and so people need to have cell phone service to contact our call center. So on one hand, and the second hand, we need to have cell signal to contact our staff. So we have backups at the office, but the families don't necessarily have backups. So if their local tower is out of diesel, then they don't have cell service. But so we're still able to operate. But I think if this doesn't clear up, it could get like really difficult.
Yeah, clearly. You'd also think that the gangs that are blocking the terminals need cell tower to communicate with each other as well. So maybe they can carve out some exceptions. But, you know, I would think that the local telecom providers are probably engaged in those conversations. Who knows? But those are certainly big challenges that you're dealing with. Now, another thing that happened was, and you've mentioned Les Cayes, was the earthquake in 2021 in Les Cayes. There was another earthquake in the southwest of the country, where before that you were only in Gressier, but then after the earthquake happened, you launched, as you're saying, a satellite program. What was the need that you recognized that caused you, you know, that inspired you to say, we're going to launch this program, this satellite, and how did you go about doing that? I mean, because it took a fair amount of time for you to set up the Gressier program, but as I was watching, you were able to launch the satellite program pretty quickly. How did that work?
Yeah, so the need that we saw was like right after the earthquake, there was a lot of like emergency responders and like field hospitals and, you know, people ready to respond to trauma, with like what you would expect after an earthquake. And, you know, but they were only intended to be in the area for, you know, like a short period of time, maybe maximum like 2 months. And so we went out there and also kind of conducted like a let's call it a superficial needs assessment. And weren't really sure like if there was a place for us, but we realized a lot of the healthcare infrastructure was damaged. So I wouldn't say like buildings collapsed, like, you know, you wouldn't see the local hospital or clinic like imploded, but they weren't safe to be occupied. And so there's definitely like a diminishment of like healthcare access, and especially like basic healthcare access, because these are like your general clinics that weren't maybe like the biggest, nicest, beautiful hospital in town. So those were kind of closed down. or being repaired. So we saw like maybe a need, and we always think there's a need for MotoMeds, but you could say an increased need for MotoMeds at the time. And yeah, you're right. It was a pretty quick kind of deployment. And I think that was because we had already developed the like standard operating procedures and clinical guidelines and dispatch networks. So it was really a matter of like recruiting and training employees, which I said before we had done through like trusted contacts. So it was probably, we did our training 1 week, we launched the next week, we did kind of like a supervised launch. So we did that for maybe like 2 weeks, and then they were ready to operate on their own.
And how did what kind of numbers were you seeing in terms of compared to Gressier?
So yeah, so Les Cayes is the third biggest city in Haiti. And we had to kind of delineate a delivery zone when we decided to launch there, because we can't send the motorcycle drivers like an hour away, and they're going to be less familiar with the areas. So we kind of sectioned off like the more urban areas of Okai, which I think had around like a population of about like 80,000, but we were getting about an average of maybe you could say 3 calls a night versus like 1 in Gressier. We did have a little difficulty responding to some of like the camps. So they had some camps set up for survivors who had lost their homes. And what would happen is someone would call the service, like either a nurse or a driver would show up with medications, and it's because it's like a very densely packed area, and a lot of people sharing like homes. Like they would have these camps like on a soccer field or something like that. People would, let's say, they'd all want to use the service, and we just didn't have like the capacity for that. And they were tending to use the service more of like a kind of, let's say, like a daytime clinic. Like they didn't have something that needed to be emergency. They didn't have an issue that needed to be addressed at night. They were just maybe concerned about their child. They wanted a basic checkup. They thought maybe we were handing out vitamins. So that didn't work so well. Like these camps for displaced people were probably not the right target population for MotoMeds.
Right, that makes a lot of sense. So now you've got these 2 programs running in Gressier and in Les Cayes. Has the government taken any notice of what you're doing? And to be fair, the Haitian government has their hands full, right? There's no doubt about that. So
yes. So I would say there's people within the government who have. So we because we're operating within the umbrella of research, we have our research studies approved by the National Bioethics Committee, which works with the Ministry of Population and Health. So they're aware of our work and support our work. We also have a partnership with the State College of Medicine. So the Dean of the College of Medicine and others there support our work and have put us in contact with Haitian physicians who are co-investigators in Haiti. And then locally in Gressier, the like government clinics are aware of our work. We've advertised with them, but I wouldn't say they're in a position to kind of like integrate MotoMeds into their services at the moment, which would be great.
Yeah,
a possibility.
Clearly. But you do have participation. In fact, with the IRB, they've signed off on this. They are fully aware of what you're doing. It's just more of a question of bandwidth and stability, I guess. Obviously the Haitian government has been going through some significant problems over the couple past years. That's awesome. So now what's the plan for MotoMeds? What's the future look like, or what are the aspirations that you're going for?
So we've spent, I guess, 5 years building MotoMeds, and I guess the immediate goal is to create a system that could be handed off to other organizations or governments to implement. One of the I guess biggest steps to get, or two big steps to getting there, is to digitize our clinical guidelines. So our clinical decision support right now is all on paper, and it's a lot to learn. And I think if it was digitized, it would be easier to follow, as well as easier to transfer to new locations, new providers, new organizations. And then the second thing is to try to see how exportable MotoMeds is, the MotoMeds model, to other settings. So right now, we're about to launch MotoMeds in Ghana with the National Ambulance Service, in partnership with them, to see what a different population, how they respond. And it will be interesting there because there's a lot of malaria, which we don't have in Haiti.
Fascinating. So really love what you guys are doing. You and Dr. Eric Nelson have been at this for so long, and it's really showing some impactful results. Is there anything that you'd like to share that I haven't hit on, or that I've left out? Any, lessons learned or advice for other groups that are looking to start community response programs like you're doing?
I mean, I think involving the community, there's no way we would have been able to build MotoMeds without, like I said, the local drivers, the fact that our nurses are part of the community. That just wouldn't have been able to happen without that.
Yeah, it's fantastic. And you've been in Haiti for quite a while. How long have you been living in Haiti for?
11 years.
That's a long time. That's fantastic. Great. Well, thank you so much, Molly. Really appreciate it. Always a pleasure to catch up. Appreciate your time, and also look forward to getting updates from you. And also, once MotoMeds in Ghana gets up and running, that'll be exciting to see as well.
Mm-hmm.
Thank you so much for your time. Always a pleasure, and enjoy the rest of your day.
Thanks, you too.